Wonderful. Good afternoon from Boston, Massachusetts, which is where I am located. My name is Sarah McKinnon. I am co-chair along with founder Dr. Kate Barlow, who's also located in Massachusetts. And together we continue to bring you opportunities monthly to help support your professional development, build community and network around the world related to occupational therapy and the health professions. I'm so excited today to welcome our guest speaker, Dr. Nikki Beatrice, who is also located in Boston, Massachusetts. She'll share a bit about her and her topic, trauma-informed care principles in behavioral health occupational therapy. I'm not sure if when you got this topic today, you were so intrigued because maybe you don't use this language, maybe you don't know what trauma-informed care is, or even behavioral health. We have such a role as occupational therapy practitioners in this space, and Nikki is our expert bringing that in. So to share with you what we'll do to get started today, Nikki will be presenting today, a mini lecture, if you will, for about 20 to 25 minutes. We'll have some time for a Q&A. You can feel free to use the chat box for that. And then we will be breaking up into small breakout rooms today where we'll dive into a case study for about 10 minutes or so and come back to the large group where Nikki gives us her expertise and helps facilitates the case study together as a large group. This session is being recorded, and again, we thank you very much for being here. As you know, we thank you for your completion of the surveys, pre and post. And also hope that you enjoy receiving your certificates of attendance after joining us today. All right, so take it away, Nikki. Thank you so much for your time today.
Thank you, Sarah. Hi, everyone. My name is Dr. Nikki Beatrice. I'm super excited to be here. Like Sarah mentioned, I am also in Boston, Massachusetts, and I'm very excited to share this topic, which is kind of my specialty in occupational therapy. So without further ado, let me see if I can change. There we go. Awesome. So after our kind of talk today, my hope for you all is that you'll be able to recognize signs and symptoms of trauma and stress, both what it looks like for maybe you or your colleagues, as well as our patients. I really believe that we need to be able to understand what signs and symptoms look like on us so that we can better assess it in our patients as well. I hope that you can demonstrate an understanding and how to assess some of these patients' triggers, which we'll talk a little bit more about their behavioral warning signs before an escalation occurs, and then maybe determine what trauma-informed technique or intervention you may want to use to implement into your day-to-day practice. So a little about me quickly is that I graduated in 2017 with a master's in occupational therapy from Worcester State University, a small state school located about 45 minutes outside of Boston. And last May in 2023, I graduated from the post-professional occupational therapy program with my doctorate in OT from the MGH Institute of Health Professions, where I really was able to dive deeper into what my passion was in occupational therapy and had really great mentors that kind of helped guide me into this presentation today. I started off with the intention of wanting to work in pediatrics. That's part of the reason I got into OT was that I had worked with kids primarily with autism. And what I found during school when I was given my fieldwork experience and placed in a psychiatric placement was that I actually really fell in love with working with patients with psych needs. And originally, I absolutely had you had asked me during school if I would be where I am today, I would say I had no idea. So I worked for a therapeutic school for kids with PTSD for about 2 years and started off their OT program and then transitioned to a bigger medical center. I'm located at Tufts Medical Center in the heart of Chinatown in Boston, Massachusetts. I started by working on our inpatient psychiatric unit. It's a 20-bed medical psych unit and have developed a consult service across the entire medical center where I oversee OTs working in behavioral health. You'll hear me interchange the words psychiatry and behavioral health. In my opinion, I believe that the term behavioral health encapsulates so much more than just the typical term of psychiatry. And oftentimes, we, even still in 2024, hear a lot of stigma of language used in psychiatry, and behavioral health is more of this broader term that we use, which helps identify multiple different types of patients. So that's a little about me. So occupational therapy is rooted in mental health, right? That's where we really learned about our scope. After the war, many people with brain injuries or what was considered shell shock syndrome at that time, and OTs really were able to be at the forefront of going into hospitals where patients were waiting months, days, years, um, and were oftentimes left in straitjackets or kind of ostracized from society. And when OT was able to go in and provide therapeutic and meaningful activities, we really saw people recover and heal. But now in 2024, at least in the US, less than 5% of OTs work in mental health. It's really shifted to any of the other populations. And what's so amazing about OT is that there are so many populations and settings that we can work with patients. And my scope really lies within that mental health and kind of where we started. So at my facility, I just have a kind of general list of some of the OT goals that we kind of practice. And so I won't list all of them. You can see them here, but things like helping patients identify their coping skills, helping them with emotional regulation, promoting daily routine and structure, and increasing their independent living skills are just a few of the goals that we work on in my facility. This is an example of our day-to-day group therapy schedule. So at our facility, like I mentioned, it's a 20-bed medical psychiatric unit. It is located in a level 1 trauma center. It's a teaching hospital, which is great because we have residents and a really large multidisciplinary team that comes together. And patients are able to get both medical work done while also receiving treatment for their mental health, which is really wonderful. While there's other hospitals that are just freestanding psychiatric hospitals, we're able to see everything. So whether it's patients with comorbidities such as, congestive heart failure and depression, or perhaps uncontrolled diabetes and bipolar disorder, we're able to treat the entire patient, which is really wonderful. Our occupational therapists are fully responsible for our group programming. Prat2 is the name of our inpatient psych unit. And this is kind of what our day-to-day routine and structure looks like. It's 12 hours from 8:30 a.m. to 8 p.m., filled with groups. And most of these groups are led by OTs, like I mentioned, but we do have some really awesome interdisciplinary players that come and help us assist with groups. We have a music therapist. We have our hospital chaplains come and run spirituality group once a week. We have Smart Recovery, which is kind of like an alternate to AA. We have 2 hospital facility dogs, which you might hear me talk about a little later, that come and do facility dog visits with our patients. But this is kind of our general groups when we talk about our inpatient psych. On the right-hand side here, this is our behavioral health crisis prevention tool. So this is what we use for all 20 patients that come in. It's part of our occupational profile when we think about initial screens for patients. What's really great about this crisis prevention tool is it provides autonomy for the patient. So we get to ask the patient, what are the things that are helpful for you so we know how to best support you? And what are the things that are not helpful so we know how to best avoid it? So on the top left-hand side, there's the triggers. So it says, what are some things that make you upset or angry? And it allows the patient to tell us things like, I really don't like loud noises, or I have a really hard time with security officers. And that's really important for us to know because we have 24-hour security presence, public safety on our unit. And so it's important for us to identify what triggers may be happening for the patient when you think about an inpatient psych unit where patients are on a locked unit where they're free to kind of walk around in what we call a milieu setting, meaning that they have access to go in and out of their rooms, in and out of the kitchen. We have a TV room. We have a little library room. And so everyone is really functioning and kind of living on this unit freely together. And so it's important when we talk about, what are the things that may trigger you so that we're very aware of it in this public setting. We also identify their behavioral indicators. So that is, what is it that when you are in a sign of crisis, how will we know that you're having a hard time? So some patients may say, I start really escalating. I start getting really verbally aggressive. I start swearing, or the opposite, I start crying, or I isolate myself. And it's really up to the patient to be able to tell us what's helpful. And lastly, we go over coping skills. Here are the coping skills we offer on our inpatient psych unit. What is most helpful for you? What do you think is going to be helpful? Or maybe you've never tried any of these things before. And so it's just a matter of kind of exploring it together, discussing what coping skills may be helpful and what's not helpful. Something that's not on this side of the crisis tool, but is usually on the back side, is a patient's trauma history. And what I like to say about understanding trauma for our patients is that 75% of our patients have some sort of trauma history. And while we don't want to ask the patients exactly, tell me your entire trauma history, right? Because we know that that would not be supportive or helpful. It is helpful to understand what kind of category of trauma the patient might have experienced so we know how to best support them. Meaning that if a patient has experienced a lot of physical violence or a sexual assault, it is important for us to be aware as a team when thinking about how to provide trauma-informed care and interventions, which we'll talk about a little bit later. Okay, here is where I would love for you to start writing in the chat box. I would love for you to tell me, what are your signs and symptoms of stress? If I didn't know you, and for a lot of you, I don't, I want to know, what does stress look like for you? Signs and symptoms. Is it that you are someone who really shuts down when you get stressed? Is it that you begin to cry? Is it that you don't have as good of sleep as you normally would? What does stress look like? What does it also look like in your body or feel like? And then this last question here is, how would someone else identify that you're having a hard time? So maybe choose one of these three questions and drop in the chat what that looks like for you. Migraine, yep. Burnout, insomnia, acne on the forehead, headache and overeating, tired, totally. Shutting down, lack of sleep. Yep. Awesome. And what's super important about being able to identify what this looks like for us is a few things. One being, it's easier for us to identify when someone else is having a hard time if we're able to identify it within ourselves, right? And part of occupational therapy in psych settings is emotional intelligence and being able to provide the education on using words to describe emotions. Oftentimes, when we talk to our patients, every morning we have group rounds with the psychiatrist, the social worker, the nurses, the OTs, the resident doctors. This patients will come in and we'll say, how's your night? How are you feeling? And the patients often will say, I'm fine. I'm good. I'm okay. And those words are fine to use in kind of your social settings of maybe passing someone on the street and asking how you're doing. But when we're talking about being on an inpatient psych unit for your mental health, it's really important to really talk about in detail, what is that emotion for you and what does that look like? So words like okay, fine, or good are really hard for us to identify as practitioners, how to best support someone. And so we do something called an emotion wheel, where we have patients with about 60 different emotions and we define them. What does it mean to be scared? What does it mean to feel jealous? What does it mean to have shame? And really be able to pinpoint the emotion that the patient is actually feeling in the moment so we know how to best support them. And so that's kind of why I love asking this question, is to kind of gain that understanding of what stress looks like, feels like, how can we talk about it more, so that there's a better understanding than just saying, I'm feeling fine or good. Awesome. Thank you guys so much for dropping that in the chat. The next thing we're going to do is look at what the actual definition of trauma is. So trauma is defined as a subjective event or series of events, or perhaps set of experiences that is experienced by the individual as physically or emotionally harmful, causing long-lasting effects. And the reason that I bold subjective is I'm really thinking that a trauma is based on person to person. Subjective meaning that what I may experience is different and looks different than perhaps Sarah or Kate or each and every single one of you. We all may be in a room and something may happen, and we all experience it differently based on our environmental, based on our supports, based on our resiliency. And I think a great example of that is COVID-19 and the impact that it had on each and every one of us across the globe, but it impacted us all different. I've heard so many stories on how COVID really impacted people, from, not being able to have access to medications to not being able to, I don't know, graduate from high school or college in person and having to do it online. So it really, everyone's stories are so different. And that's really that subjective piece, is that trauma looks different for every single person. And so we can't, when we talk about trauma, we can't compare, because everyone's experience is individual to them. Okay. So here are some common signs of trauma. It's broken out into physical, emotional, and behavioral. And you can read through some of these, eating or drinking too much or too little, stomach or sleep issues, headaches, right? We know that trauma impacts us from a physical and emotional level, but how does it change us in a behavioral sense? What I'd love for you to do is look on the left-hand side at um, this picture. And what we call this is the window of tolerance. Um, Everyone, all of us, have a window of tolerance. That is our ability to withstand emotion on the day to day, being able to experience highs and lows. So anything that is really above that top line is your hyperarousal, kind of your survival senses. Fight, flight, I think of like stress response. I saw like the kind of heightened behaviors, where everything under that bottom line is hypoarousal. That's kind of your freeze, your submit, more of your depression symptoms, isolation, that kind of thing. And so throughout our day to day, we all go through emotions and have a window of tolerance. Our window of tolerance can increase and decrease depending on our environment. So if I had a really good breakfast today and I didn't have any traffic on my way to work, and I feel really supported by my boss and by my family and friends, I may feel my window of tolerance is much larger than on a day where I didn't get enough sleep. I don't really feel that well. I don't feel supported by the people around me. I might have a shorter window of tolerance and be more irritable or snappy, or some of those things we talked about in that trauma or stress identification. When patients who have experienced trauma, what happens physically in their body and in their brains is that their window of tolerance automatically decreases to a much shorter level than someone who has not experienced trauma, meaning that their window of tolerance gets bounced out much easier. Much easier and faster than someone who has not experienced trauma. And so oftentimes we see really big emotions for something that we may classify as a small event. Because of that window of tolerance, they're not able to regulate their emotions from a biological standpoint. And so our work as practitioners and as occupational therapists is to sit with patients in that optimal arousal zone. We want to teach coping skills. We want to offer support so that we can increase that window of tolerance. And we call that our optimal arousal zone. I know I'm speaking fast, and I'm happy to take questions after this as well. Okay. All right. So here's the bread and butter here. Trauma-informed care. There are 6 principles. Trauma-informed care is kind of an umbrella term, meaning the way that we as providers assist patients who have experienced traumatic events. There are 6 principles. We'll quickly, briefly touch upon each of them. And what you should know is that we can identify how we use trauma-informed care through things like this: interprofessional collaboration, through understanding health effects, and how trauma affects the brain and the person. We can use trauma-informed care when we talk about documentation language and how we provide care to patients, and through screening tools like the crisis prevention tool I showed, and through understanding our own history and reactions. So understanding that each of us has our own story and our own experiences in life, and that we have to keep that in mind when dealing with patients, and how that kind of brings up certain emotions for us. So the 6 principles of trauma-informed care, we start with understanding trauma and stress. From that biological standpoint, what happens to the brain when you've experienced trauma? How do we understand what our patients are going through, by understanding physiologically what's happening for them? So that's at the beginning very important for us to understand. Secondly is compassion and dependability. So us as practitioners having compassion, hopefully we don't have to really teach that. It's something that we all have as part of the profession and choosing occupational therapy, right? But dependability is a really important thing. And I know that it looks very different, depending on what setting you're working with patients. I know for me on our inpatient psych unit, oftentimes when someone has experienced trauma, they patients report that they feel on edge or that they can't trust other people, and that it's hard for them to build relationships and trust. So being dependable is really important for them. And so what I stress to my staff is that if we say we're going to do something, we stick to it. Meaning if I say the group starts at 10:30, then I expect my staff will be there at 10:30 to begin group for the patients. Because if not, I might have patients that are upset or patients that are waiting at the door saying, "Where were you? You promised that you were going to be here at 10:30." So that's the second. The third one is cultural humility and responsiveness. That is understanding that I will not look like or sound like or have the same experiences or cultural experiences as many of my patients, and understanding that, understanding different people's complexities and other people's cultures and how that affects them, on their day to day, and the treatment that we provide. Working in Chinatown where we work in Boston, we often have a lot of Cantonese and Chinese speaking patients that are fluent. And by providing the same quality care, we are getting translator services and have different ways for the patients to feel that they are still getting the same care as someone who speaks English. And so I think it's really important to understand, obviously, everyone's different backgrounds and how to best support and work with them in our different cultures. The next one is safety and stability. So understanding that we want our patients to feel safe before anything else. If you don't feel safe, then how can you work towards learning coping skills or learning some of the other things that OTs can teach, and having a safe place physically, to be. Next is collaboration and empowerment. So collaborating with the interdisciplinary team, collaborating with our patients, collaborating with their family members. It's really important to have everyone be on the same page in this team. And lastly, resiliency and recovery, which is what I think OT has a huge standpoint in, is our job as OTs is being able to increase resiliency for these patients, increase their ability to recover, just like we did at the start of OT and mental health years and years back. And we do that through coping skills, through group programming, through providing education. And I think that that's where OT really lies in this trauma-informed care principles. Okay. I know we're going to break out in a just maybe 2 or 3 minutes into a case study, but I just wanted to highlight some interventions that we do when we think about patient-centered interventions. One of the things that we do on the left-hand side is a reorientation board. So this is when someone comes in, we will ask them, what are your preferences? What do you like to do versus not like? What kind of foods do you like? We know you're going to be in the hospital. How can we best support what your preferences are? Some facts about them. Some of our patients are open to having a photo. Some are not, and that's okay. But this is just an example of what a personal preference board would look like. We often do reorientation boards for patients too who may be confused or have a cognitive um, deficit. So this reminder, right? You are safe. You are at Tufts Medical Center with the date, and it's usually posted right above their bed so that they have access to see it. We do a lot of work on normalizing the diagnoses of our patients. So this is an example of a comic after a traumatic brain injury, but we have them for all different diagnoses, being able to put it into simpler terms for our patients to understand. Some other interventions. Again, this is one of our patients who is from Hawaii and didn't really have any family or support while he was here in the hospital, but was able to have access to his phone and send me photos to my email of Hawaii, his family, the island he was on, some of his favorite leisure activities, and we were able to print it out and put it in his room for him to feel that sense of home, to feel safe in this environment. And we also provide things like access to meaningful activities, whether that's music with a radio, a sound machine to help people sleep, access to tea, which is really big in a lot of cultures, is not a lot of coffee drinkers, but we have a lot of patients who love drinking tea. So we have access to that, games, cards, journals. So things that make patients feel safe and comfortable and willing to allow them to engage in treatment. Okay. Oh, and last but not least, this is our zones of regulation. This is another intervention that helps us identify what the patient is feeling, along with some tools that they can integrate and be able to identify and use. This is Bob and Dottie, our hospital facility dogs, like those two dogs I talked about earlier. And we use them a lot for a lot of our education, because the patients love it and we love it. And it's a really great way to highlight some of this work. Okay. Okay. I see something in the chat. Let's see. Perfect. All right. We are going to do our case study. So what I'm hoping to do is just kind of, Sarah and Kate, I can present it first if you think that's best, and then we'll break out into rooms. Great. Okay. So for our case study today, we are going to highlight Sammy. Sammy is a 24-year-old female. She uses she, her pronouns. She's a 24-year-old female. She lives alone in an apartment in Boston. She's depressed after a recent breakup. She was brought in by ambulance for overdose on NSAIDs. So that is things like Tylenol, Advil. Her parents report she consumed a bottle of 200 pills of Tylenol. They went to her apartment after concern from not hearing from her. They found her with vomit on herself and her bed sheets and called 911 immediately. She spent 4 days intubated in the ICU and was stepped down to a medical surgical floor. This often happens while we're waiting for a patient to be medically cleared before they can come to a psych unit. So she is waiting to come to a psych unit right now. Her past medical history, she has PTSD, major depressive disorder, anxiety, and a family history of substance use disorder. Her trauma history is that she was sexually assaulted from the ages of 10 to 14 by a family uncle. And the reason we include that is because it's really caused a rift in the family. So there's some family dynamics there that are really challenging for Sammy. The collateral or conversation we had with her family is that her parents say that at baseline, she's a bright young woman who experiences a lot of anxiety. She works full time at a record store. She loves music. Her boyfriend of 5 years recently broke up with her, and Sammy began to isolate and stay in her apartment more. She stopped attending work about a week ago, and her parents report she's recently become more moody and snappy and demonstrates some manipulative behaviors in order to get what she wants. Okay. So with that, her triggers are being touched, not having choices, loud noises and yelling, being around men. and people in uniform or security. Her behavioral warning signs are self-harm, like biting or headbanging, irritability, becoming loud, fidgeting, and elopement, which means trying to leave the hospital. But her coping skills are music, art, warm tea, playing cards, yoga, and deep breathing, and taking a cold shower. She told us on the coping safety tool, if she's having a hard time, we can approach her right away. So here are the questions that I'd like you to think about from knowing what we know about Sammy. What other information would be important to know? What information would be the most helpful in passing along to the rest of the interdisciplinary team about her triggers if she were to become escalated in a hospital room? As an OT, what interventions do you think we should work on with her first? And what goals may you address with Sammy when we're talking about a treatment plan? So I'd love for you to break out into those breakout rooms, and then we can kind of come back and have a bigger discussion.
Start the recording for those who are just joining us virtually through the recording. We're coming out of our ECHO case study breakout room. And we're going to spend our last 7 or 8 minutes or so with Nikki leading us off with this case study. Please, I encourage your participation, but we might ping just a few of our facilitators. So take it away, Nikki.
Awesome. Thank you, everyone. So hopefully in your small breakout groups, you were able to kind of really discuss what kind of interventions you do with Sammy, or what part of the what you'd pass along to the interdisciplinary team. I know it was a pretty quick breakout room, but I'd love to hear, what were some of the discussions that you had in some of these breakout rooms? Maybe some of the facilitators can jump on and give a little briefing. What do I see here? Antonio, were you one of the facilitators? You want to give us a little overview?
Sure, you want the answers for all the questions?
How about we focus on what information you'd pass along? So maybe number 2 and 3.
Well, we'll discuss about any particular fears Sami may has, ask about the history of her family over depression or other mental health issues, and discuss about other incidents and if there was any medical investigation carried out following the rape incidents. Then with the rest team, we would talk about the fear of being around with men and that loud noises and yelling may trigger her. And shall we go on for the third and fourth question?
Sure. How about what's like a one goal that you would use to address Sammy?
Well, we talked about many things, mostly about the social interaction. So she could gain again trust to men step by step, uh, bringing her in small groups for gradual exposure, engage her in activities she chooses to engage in, so she could enlighten her mood, create comfortable environment, maybe peer groups for substance misuse and psychoeducation.
Perfect. Those are all wonderful. And what I really love hearing is 2 things that stuck out that you said. One is safety, right? Trying to get Sammy to feel comfortable again, because at the very root of everything, we want our patients to feel safe before we can talk about anything else, right? And so I think that that's awesome. And secondly, I think you mentioned something around autonomy or choice, and giving her access to choices. That's a huge part of trauma-informed care, is giving our patients some sort of choice so that they feel that they're in control. So that's wonderful. Thank you so much.
You're welcome.
Awesome. How about one of our other facilitators? Anything that came up in terms of interventions or goals that you would use to support Sammy?
I can go.
Sure.
Okay, so in our group, one of the some of the things that we said we could give the information to the interdisciplinary team was about the tendency to elope. Since she'll be in the hospital, they have to know that she has that tendency. And her manipulative behavior to get what she wants. I think that is an important detail for them to know, and her post-traumatic history. And the last information that they require is for her to work closely with the social workers and the psychiatrist because of her depression and her history of sexual abuse. And our goals were, one of them is working on the zones of regulation, like giving more of the coping mechanism, coping skills, relaxation techniques, stress management, and all that. We also talked about social participation and community integration. Lastly, returning to work. That was our long-term goal. So yeah, thank you.
Awesome. I love all of that. Again, using zones of regulation is this really great intervention that we can use everywhere. And you can use colors to identify emotion. You can use pictures, words, expressions. It's really a great tool to use and be able to identify in many different areas. So I love that you used that. And really getting the multidisciplinary team involved, social work and psychiatry. So important for us as OTs.
I love that. That was really, there were some really great answers. I think what I'll do with just our final few minutes, Nikki, one is I do want to offer the opportunity for any questions for Nikki for her practice. You can put them in the chat or feel free to raise your hand. And to fill the space too, Nikki, sharing any of your own insights, working with this population, with clients like our case study daily. Is there anything kind of unique or tips or tricks that you think would be really helpful for this group to know more about?
Sure. So I did put up a slide just as a general over conclusion of, the three main things that I think are the takeaways are building a sense of safety, right? For our patients, whether it's us being safe as providers, being that safe person, that trusted person, as well as a physical space that they should feel safe. Predictability is really important. So being in the know of their treatment, having boundaries and structure and routine, and then giving them that control or autonomy that we talked about, giving options and choices when possible, being able to identify when a patient's having a hard time and being able to help with facilitate some co-regulation is really important and part of trauma-informed care, and providing a lot of validation and active listening strategies. I'm a talker. I don't know if you can you can see that through the screen, but I love talking, and something I've learned so much in working with psych patients and trauma-informed care is my ability that I need to learn to listen. Listening is so huge. So much. Oftentimes our patients are talked to all day by other providers, by doctors, by social workers, by nurses. And sometimes people just want to be heard. They just want someone who's going to sit and listen to them. And so at the very least, if you take anything away, being that person who just sits and listens, and that using your active listening strategies, I think creates a sense of safety in itself, and acknowledging that our patients have been through what they have, and being that safe person to support them in their journey. I love this work in psychiatry. I never thought that I would do psych work to begin with. And I think it's, you change as you're a practitioner, and with time, you change what population you work with or what you think you wanted to do. And that's the amazing part about being an OT, right? We have so many avenues, so many things that we can do.
Nikki, thanks so much for coming to join our group. Such a I don't know, beautiful feel and perspective to the profession with how you presented this topic and your work, and just even your conclusion slide and your kind words. There aren't any questions in the chat box, but we will be sure, Nikki, maybe you can drop your email in the chat. If people wish to follow up with you, they can do so. We also have a lovely shout out to our Facebook page. It's a wonderful way to stay connected around the globe. Speaking of which, Kate and I are coming a little closer to you next week when we come to Europe for the first ever European OT Congress, presenting on the work of the OT Echo and the various research studies. Amazing contributions from Dr. Kelsey Sullivan, who's part of this group, also Dr. Jahidra Castillo, and more. So we'll come back and share perspectives in some way. Maybe we'll do so on the Facebook page. But be sure to go ahead and make sure you like that page, and think of us too for some safe travels next week. All right. Thank you, everybody. Have a lovely rest of your week. And thank you, Nikki.
Thanks.